Welcome to Bookfulness. We're kicking off Deep Dive 33 today, continuing our exploration of the head's anatomy. Last time, we really got into the bones, right? The structure of the cranium itself. Today, we're going just outside and just inside that bony case. We'll be covering the face, the scalp, and those really vital cranial meninges that protect the brain.
Exactly. And our mission really is to make this complex area feel a bit more navigable, especially from a clinical angle. So we're going to break down the scalp layer by layer, all 5 of them, then trace the nerves and blood vessels in the face, which can be, well, pretty complex and sometimes risky. And finally, dive deep into the 3 meningeal layers, the dura, arachnoid, and pia mater, looking at how they fold, create sinuses, and basically keep the brain safe and sound. You'll get a real sense of the mechanics behind everything from a simple cut on the head to some serious neurological issues.
Sounds good. Let's start with the face itself. It's how we recognize each other, express emotion.
Yeah.
It's so individual. The book points out that this individuality comes from, well, a mix of things. The skull shape underneath, how much fat we have, skin, hair.
That's right. And the development is interesting too. The facial bones grow much slower than the top part of the skull, the calvaria. A lot of that facial growth actually lines up with when our permanent teeth come in. Seems like it needs to make space for the teeth and the muscles needed for chewing.
Makes sense.
And speaking of development, think about babies and those chubby cheeks. Those large buccal fat pads, they aren't just for looks, they're actually structural. They sit between the cheek muscle, the buccinator, and the chewing muscle, the masseter. Their main job is to stop the cheek from collapsing inwards when a baby is sucking. Pretty clever design.
Wow, okay, so actual structural support for feeding. Never thought of it that way. All right, let's move up top then to the scalp. The mnemonic S.C.A.L.P comes up immediately.
Oh yeah, it's classic for a reason. Each letter really stands for a distinct layer with its own clinical importance. So from the outside in, S is for skin, C is for the dense connective tissue, the subcutaneous layer. A is the aponeurosis, specifically the epicranial aponeurosis, like a tough sheet. L is the loose connective tissue, sometimes called areolar tissue. And P is the pericranium, which is basically the periosteum of the skull bones.
And clinicians often treat the first 3, S, C, and A, as one unit.
That's right. They call it the scalp proper because they're so tightly bound together, they move as a single unit. That's really relevant if you're, say, making a surgical flap for a craniotomy. You'd lift those 3 layers together.
Okay. Now, layer 4, the loose connective tissue. That one gets called the danger area of the scalp. That sounds, well, dangerous. Why?
It really is, and the danger comes down to mechanics and blood vessels. Because that tissue is loose, it offers almost no resistance. So if you get blood or, worse, pus from an infection collecting in that layer, it can spread incredibly easily all across the top of the head.
Spread easily, okay. But what makes it truly dangerous?
It's the connection inward. This layer contains tiny veins called emissary veins. These are important because they pass directly through holes in the skull bone, and they connect the veins on the outside, in the scalp, directly to the big venous sinuses inside the skull, the dural venous sinuses, which drain the brain.
Ah, okay. So infection in that loose layer can basically hitch a ride on these emissary veins straight into the cranial cavity right next to the brain and its coverings.
Exactly. Bypassing a lot of the body's usual defenses, that's how a scalp infection could potentially lead to something really serious like meningitis or even an abscess inside the skull.
That's quite a connection, but the book mentions it's somewhat contained.
Yes, structurally it is. Thankfully, infection in this layer generally can't spread down into the neck because the occipitofrontalis muscle attaches firmly to the bone at the back. And it usually doesn't spread sideways down the face past the cheekbones because the aponeurosis attaches along the temporal lines. The main place it can track is forward into the eyelids and the bridge of the nose. That's why sometimes a scalp injury or infection up high can lead to bruising around both eyes, those classic black eyes.
Right, that makes sense. Structural barriers limiting the spread.
Let's shift to the muscles then, the ones for facial expression. They're kind of special because they insert right into the skin, aren't they?
They are. That direct attachment to the skin or the underlying connective tissue is what allows for all the subtle movements we use for communication. And almost all of them are controlled by one nerve. Cranial nerve 7, the facial nerve.
Can we highlight a few key ones? Maybe the occipitofrontalis? Absolutely. The occipitofrontalis has 2 parts, or bellies, a frontal one over the forehead and an occipital one at the back. The frontal belly is the main one for raising your eyebrows. It pulls the scalp forward, wrinkles the forehead horizontally. That's the classic look of surprise or maybe curiosity. Clinicians test this look surprise to check that part of the facial nerve.
Okay. And what about around the eyes? The orbicularis oculi sounds like it does more than one thing.
It does. It's complex. It has two main parts. The palpebral part is in the eyelids themselves. It handles the gentle closing, like when you blink or sleep. It's mostly involuntary.
And the other part?
The orbital part surrounds the eye socket. This one's for forceful closure, like squeezing your eyes shut tight or winking. Clinically, this is important. If the orbital part is paralyzed, say from facial nerve damage, you can't properly protect your eye. The eye might stay open, dry out, and you risk damaging the cornea.
Right, the protective function. And then there's that muscle that makes us look worried, the corrugator.
Corrugator supercilii. Yes, it's a small muscle deep to the eyebrow, but it has a big impact socially. It pulls the eyebrows downward and medially towards the nose. That action creates those vertical wrinkles right between the brows. The classic frown of concern or worry. It's amazing how much we rely on that tiny muscle for nonverbal cues.
Definitely. Okay, so we have the muscles. Let's talk about the blood supply. Scalp wounds are famous for bleeding.
Yeah.
A lot. Why is that exactly? Is it just lots of vessels?
It's partly the density of vessels. Yes, the scalp is incredibly vascular. But the main reason for the profuse bleeding is how the vessels are anchored in layer 2, that dense connective tissue. The walls of the arteries are actually stuck, fused to that tough fibrous tissue.
So they can't constrict.
Precisely. Normally, when an artery is cut, the smooth muscle in its wall contracts, clamping it down to reduce blood flow, vasoconstriction. But in the scalp, the dense tissue holds the cut ends of the vessel wide open. It physically prevents them from constricting. So they just keep bleeding until you apply serious pressure or surgically tie them off.
That makes perfect sense. A structural reason for a physiological problem. Where does all this blood come from? Which major arteries?
It's a meeting point of supplies from both the internal and external carotid arteries. Generally, the front part of the scalp and the forehead get blood from branches of the internal carotid, specifically the supratrochlear and supraorbital arteries, which come up around the eye. The sides and the back of the scalp are supplied by branches of the external carotid, the occipital, the posterior auricular, and the superficial temporal arteries are the main players there. It's worth noting, though, that these scalp arteries don't do much for the bone underneath. The skull bone itself, especially near the meninges, gets its main supply from the middle meningeal artery, which is deeper.
Got it. And you mentioned the occipitofrontalis muscle earlier. Does it affect how scalp wounds bleed or gape?
It absolutely does, especially if the cut goes deep enough to get through layer 3, the aponeurosis. If you have a deep cut that runs side to side in the coronal plane, that wound will gape wide open. Because the frontal belly is pulling forward and the occipital belly is pulling backward. They're constantly trying to pull that aponeurosis in opposite directions. So a transverse cut releases that tension, and the muscle bellies just pull the edges of the wound apart. Makes it harder to stop the bleeding and really necessitates stitches to bring the edges together.
Okay, that's the motor side with CNED and the arteries. What about sensation for the face and scalp? That's mostly the trigeminal nerve, CNV, right?
Almost entirely. CNV is the workhorse for facial sensation. It has 3 main divisions, and they map out pretty neatly onto the face. V1, the ophthalmic division, covers the forehead, upper eyelid, the bridge and tip of the nose, and the front of the scalp. V2, the maxillary division, handles the lower eyelid, the cheek area, the side of the nose, and the upper lip. And V3, the mandibular division, covers the lower lip, the chin, the jawline, and the temple region side of the head.
And knowing that map is key for diagnosing things like trigeminal neuralgia.
Exactly. That condition causes excruciating pain, and it typically follows the path of one or more of those specific branches. So the location of the pain tells you which division is affected.
Okay, now let's follow the veins. We touched on the danger of infection spreading inward. Can we trace that venous path from the face to inside the skull? The danger triangle concept.
Yes, this is critically important. It starts near the eye. The veins draining the forehead and area above the eye, the supratrochlear and supraorbital veins, they come together near the inner corner of the eye. They form the angular vein, which runs down alongside the nose.
That's connection.
The angular vein connects directly with the superior ophthalmic vein inside the orbit, the eye socket. And that vein, the superior ophthalmic, drains straight backward, directly into the cavernous sinus, which is one of the major dural venous sinuses right at the base of the brain.
And crucially, these veins don't have valves.
Correct. No valves in these facial veins, or the ophthalmic veins, so blood can potentially flow backward. If you have an infection, say a bad pimple or boil in that danger area, the triangle from the corners of the mouth up to the bridge of the nose bacteria could theoretically travel up the angular vein into the ophthalmic vein, and right into the cavernous sinus.
Leading to cavernous sinus thrombosis, which sounds bad.
It's extremely serious, can cause paralysis of eye movements, vision loss, and can be fatal if not treated aggressively.
Okay, a very clear warning there. Let's swing back to the motor nerve, seen in these as the facial nerve. After it comes out of the skull, it goes through the parotid gland.
Yes, it emerges from the stylomastoid foramen, then dives right into the substance of the parotid gland, the big salivary gland in front of the ear. Inside the gland, it branches out extensively, forming what's called the parotid plexus. And from this plexus arise the 5 main terminal branches that spread out to supply all the muscles of facial expression we talked about.
And there's a mnemonic for those branches.
A common one is to Zanzibar by Motor Car. It helps remember the branches from superior to inferior: temporal, zygomatic, buccal, marginal mandibular, and cervical.
So damage to the facial nerve, maybe from inflammation like Bell's palsy or injury, what does that look like clinically?
It results in paralysis of the muscles on the same side of the face, ipsilateral paralysis. The signs are pretty distinctive because they affect both expression and function.
What are the key things you'd see?
Well, the person won't be able to wrinkle their forehead on that side because the frontal belly of occipitofrontalis is out. The corner of the mouth will droop significantly, often leading to drooling or difficulty keeping food in that side of the mouth. And very importantly, the eye often can't close properly, or at all, because the orbicularis oculi is weak or paralyzed.
The eye issue again.
Yes. That requires immediate attention. Eye drops, ointments, maybe patching the eyes shut to prevent the cornea from drying out and getting damaged. The asymmetry is usually striking. They can't smile evenly, blink evenly. It's often very obvious.
Okay. Before we finally go inside the skull, maybe just quickly define a few surface landmarks the book mentions. Glabella, dorsum of the nose.
Sure. The glabella is that smooth, usually hairless patch of bone on the forehead right between the eyebrows, just above the nose. For the nose, the dorsum is essentially the bridge, the main ridge running down the middle. The ala, plural, alae, are the fleshy, flared wings on either side that surround the nostrils.
And the vermilion border?
That's the sharp demarcation line of the lips where the red, pigmented part of the lip meets the regular skin of the face. It's a transition zone, very thin skin, lots of capillaries which make it red, and notably lacks sweat or oil glands, which is why lips can get chapped easily.
Got it. Okay, finally, let's cross the bone and look at the cranial meninges.
Yep.
These aren't just passive wrapping, are they? They have several jobs.
Definitely not passive. They have 3 main roles, really. First, simple physical protection cushioning the brain. Second, they provide a framework. They support the arteries and veins running over the brain surface, and crucially, they form the walls of those dural venous sinuses we mentioned. And third, they enclose the subarachnoid space. That's the space filled with cerebrospinal fluid, CSF, which gives the brain buoyancy and acts as a shock absorber.
Let's start with the outermost one, the dura mater, tough mother.
Aptly named. It is tough. In the cranium, it's unique because it actually has 2 layers stuck together. There's an outer periosteal layer that's basically fused to the inner surface of the skull bones, and an inner meningeal layer that's closer to the brain.
And these are normally stuck together.
Yes, throughout most of the skull. They only separate in specific places, mainly to enclose those dural venous sinuses. Because the outer layer is stuck to the bone, there isn't naturally an epidural space in the head like there is in the spine. So when we talk about an extradural or epidural space in the head, it's always something abnormal, something created, usually by bleeding that forces the dura away from the bone.
Right, a pathological space.
Yeah.
And it's the inner meningeal layer that folds inwards, creating partitions.
Exactly. These dural infoldings, or septa, act like internal walls that help stabilize the brain and stop it from moving around too much inside the skull. There are 4 main ones. The biggest is the falx cerebri. It's a large, sickle-shaped sheet that runs vertically right down the midline, dipping between the 2 cerebral hemispheres.
Okay. And the second one, the tentorium cerebelli, sounds really important for dividing things up.
It is perhaps the most critical divider clinically. It's a horizontal, tent-like sheet of dura that stretches across the back of the cranial cavity. It sits over the cerebellum, hence the name, and under the back parts, occipital lobes of the cerebrum. This creates 2 major compartments. Everything above the tentorium is supratentorial, and everything below it is infratentorial. This division is fundamental for neurosurgery and understanding how pressure buildup affects the brain.
Makes sense. And the other 2 folds are smaller.
Yes, The falx cerebelli is a small vertical fold between the two cerebellar hemispheres below the tentorium. And the diaphragm ocelli is a very small, circular, horizontal fold that forms a roof over the pituitary gland sitting in the sella turcica of the sphenoid bone. It has a little hole for the pituitary stalk to pass through.
And this diaphragm ocelli has a specific clinical link to pituitary tumors.
It does, a very direct one. The pituitary gland sits right underneath it. If a pituitary tumor starts to grow, it pushes upwards. As it expands, it bulges the diaphragm ocelli upwards. And lying directly on top of the diaphragm ocelli is the optic chiasm, where parts of the optic nerves cross over. So pressure from the bulging diaphragma directly compresses the optic chiasm, leading to very characteristic patterns of vision loss, often tunnel vision. That visual problem is frequently the first sign that brings someone with a pituitary tumor to the doctor.
Wow, anatomy directly explaining a clinical sign.
Oh.
Okay, these dural folds also contain the venous sinuses. Let's trace the main exit route for venous blood.
Right, so veins from the brain surface drain into these sinuses, which are basically channels within the dura. A major one is the superior sagittal sinus running along the top edge of the falx cerebri. Blood generally flows towards the back, towards the confluence of sinuses near the internal occipital protuberance. From there, it usually flows out sideways into the paired transverse sinuses, which run along the attached edge of the tentorium cerebelli. The transverse sinuses then curve downwards and forwards, becoming the S-shaped sigmoid sinuses.
And the sigmoid sinus is the final part inside the skull.
Yes. The sigmoid sinus on each side dives down towards the jugular foramen, a hole at the base of the skull. As soon as it passes through that foramen, it leaves the skull and becomes the internal jugular vein, IJV, in the neck. That's the main venous drain for the head.
Okay, now let's really focus on the cavernous sinus. You mentioned it earlier regarding infection. It sits on either side of the pituitary fossa, right? Why is it so complex and dangerous?
It's unique. It's not just a simple channel, it's more like a sponge-like space filled with crisscrossing fibrous strands located on either side of the sphenoid bone body. Its danger and complexity come from the sheer number of absolutely critical structures that either pass through it or run embedded in its walls. We have to be very clear about which is which.
Okay, what's running right through the middle of the sinus, bathed in venous blood?
Two key structures. First, the internal carotid artery. Yes, a major artery running right through a venous channel. Second, the abducens nerve, cranial nerve 6th, which controls the lateral rectus muscle of the eye, moves the eye outwards.
So CNAI is particularly vulnerable there.
Extremely vulnerable. Any increase in pressure within the sinus from infection, thrombosis, or trauma is likely to compress CNDI first, leading to an inability to move the eye outwards. That's often an early sign of cavernous sinus problem.
And what about the nerves in the lateral wall of the sinus?
Embedded within the tough dural wall itself, running alongside the venous space, are 4 other cranial nerves, from top to bottom, roughly. CN third, oculomotor, CN feet trochlear, both involved in eye movements, and then the first 2 divisions of the trigeminal nerve, CNV1 ophthalmic and CNV2 maxillary, providing sensation.
So problems affecting the wall itself might hit those 4 together.
Often, yes. Things like tumors invading the wall or chronic inflammation might present with a combination of eye movement problems from 3rd and 4 and facial numbness from V1 and V2. It creates a specific clinical syndrome.
This sets up the scenario for that clinical box on arteriovenous fistulas. What happens if the internal carotid tear is inside the sinus?
Usually due to severe head trauma, like a fracture at the base of the skull. If that internal carotid artery tears while it's inside the cavernous sinus, you suddenly have high-pressure arterial blood pouring directly into this low-pressure venous space.
That sounds chaotic.
It is. The pressure inside the sinus skyrockets. And because the veins draining into it, especially the ophthalmic veins from the eye, have no valves, that high pressure forces blood backward into the orbit. The result is a dramatic sign called pulsating exophthalmos. The eyeball literally bulges forward, exophthalmos, and visibly pulses with the heartbeat. Plus, the high pressure wreaks havoc on all those cranial nerves running through or nearby. It's a surgical emergency.
Wow. Okay, the second big clinical point about sinuses involves metastasis cancer spreading from elsewhere. How can something from the abdomen or pelvis end up in the head via veins?
This relies on a valveless venous system that connects the pelvis, abdomen, and thorax with the base of the skull. Specifically, the internal vertebral venous plexuses, IVVP veins, running up and down inside the spinal canal, are valveless. And these IVVP have direct connections to the dural sinuses at the base of the skull, particularly the basilar and occipital sinuses, which are also valveless.
So no valves means blood flow can reverse.
Under the right conditions, yes. Anything that significantly increases pressure in the abdomen or thorax, think really forceful coughing, straining hard like during heavy lifting or constipation, the Valsalva maneuver, or even pressure from a large tumor can momentarily overpower the normal flow towards the heart. Venous blood can be forced to flow up the IVPP, carrying whatever is in it, maybe bacteria from an infection or cancer cells from a prostate or pelvic tumor, directly into those basal dural sinuses.
So it bypasses the lungs and liver, the usual filters.
Exactly. It's a direct route for things like prostate cancer cells to travel from the pelvis straight to the bones of the skull base or the meninges, explaining why certain cancers have a tendency to metastasize there.
That's a fascinating, if slightly alarming, anatomical pathway.
Okay.
Let's move inward again, past the dura to the leptomeninges, the arachnoid and pia mater.
Right, the slender meninges. The arachnoid mater is the middle layer. It's delicate, sort of filmy. It's pushed up against the dura, separated only by a potential subdural space. Its name comes from the spiderweb-like strands, the arachnoid trabeculae, that reach across the space below it to connect to the pia mater. The pia mater is the innermost layer, tender mother. It's very thin, vascular, and it clings directly to the surface of the brain and spinal cord, following every single groove and contour. It's inseparable from the brain tissue.
And the space between the arachnoid and the pia is the subarachnoid space, filled with CSF. We need to get that CSF back into the blood, right?
They do. CSF is constantly being produced, so it needs to be reabsorbed at the same rate to maintain normal pressure. That job falls to the arachnoid granulations. These are little mushroom-shaped projections of the arachnoid mater that actually poke through the meningeal layer of the dura and stick up into the dural venous sinuses, especially the big superior sagittal sinus. They act like one-way valves. When CSF pressure is higher than the venous pressure in the sinus, CSF filters through the granulations back into the bloodstream.
Neat mechanism. Let's quickly trace the flow of CSF from where it's made, mostly in the ventricles.
Primarily in the choroid plexuses within the ventricles. It starts in the two large lateral ventricles, one in each cerebral hemisphere. From there, it flows through small openings, the interventricular foramina of Monro, into the single midline third ventricle. Then it goes through a narrow channel, the cerebral aqueduct of Sylvius, which passes through the midbrain down into the fourth ventricle, located between the pons, medulla, and cerebellum.
And the fourth ventricle is the exit point to the subarachnoid space.
Yes, this is critical. CSF can only get out of the ventricular system and into the surrounding subarachnoid space through three tiny holes in the roof and walls of the fourth ventricle: the single median aperture of Magendie and the paired lateral apertures of Luschka. If any part of this pathway gets blocked, especially the narrow aqueduct or these small apertures CSF backs up, the ventricles swell, hydrocephalus, and brain tissue gets compressed.
Okay. Before we hit the big topic of bleeding, let's touch on headaches. The book links some headaches to the dura itself. How does that work?
The dura mater, unlike the brain, is quite sensitive to pain, especially where blood vessels pass through it or where it's stretched. The theory behind many dural headaches is that tension is being put on those pain-sensitive structures. This could be arteries at the base of the brain or the large veins entering the sinuses near the top of the head, right where they pierce the dura.
And the classic example is the headache after a lumbar puncture.
Exactly, the post-LP headache. When you do a lumbar puncture, you remove some CSF from the spinal subarachnoid space. This reduces the total volume of CSF cushioning the brain. With less fluid buoyancy, the brain can sag slightly due to gravity. This sagging pulls on the dural attachments and, more importantly, on those bridging veins and arteries where they anchor into the dura. That stretching irritates the pain-sensitive dura, causing the characteristic headache, which is often worse when upright and better when lying flat.
That makes sense. Okay, finally, the major clinical topic, intracranial hemorrhages. We need to clearly distinguish the key types mentioned: extradural, or epidural, and subarachnoid. Let's start with extradural. Location: vessel.
Extradural means the blood collects outside the dura mater, in that potential space between the dura and the skull bone. It's almost always caused by trauma, specifically a skull fracture, and the bleeding is usually arterial. The classic vessel involved is the middle meningeal artery or its branches, which run in grooves on the inner surface of the skull and can be torn by a fracture, especially in the temporal region.
Arterial bleeding. That sounds fast.
Extremely fast. Because it's arterial pressure pushing blood into that confined space, the hematoma expands rapidly, stripping the dura away from the bone and compressing the underlying brain.
And this leads to that classic dangerous presentation, the lucid interval.
Precisely. The patient might get hit on the head, maybe briefly lose consciousness or seem stunned, but then recover and seem perfectly fine talking, walking around. That's the lucid interval. But meanwhile, the artery is still bleeding. The pressure inside the skull is rapidly rising. After minutes or maybe a few hours, the increasing pressure overwhelms the brain, leading to a sudden decline, drowsiness, confusion, coma, and potentially death if the pressure isn't relieved surgically very quickly. It's a neurosurgical emergency.
Okay, very clear. Now, contrast that with a subarachnoid hemorrhage. Where's the blood here?
Subarachnoid means the blood is within the subarachnoid space, the space between the arachnoid mater and the pia mater, where the CSF normally circulates. So the blood mixes directly with the CSF.
And the cause is usually different, not trauma.
Typically, no. The most common cause is the rupture of a pre-existing saccular aneurysm, often called a baryaneurysm. These are little balloon-like weak spots on the arteries at the base of the brain, often where arteries branch, like in the circle of Willis.
So it's usually arterial blood again, but released directly into the CSF space when the aneurysm bursts. What are the hallmark symptoms?
It's usually incredibly abrupt. The absolute classic symptom is the sudden onset of an extremely severe headache, often described as the worst headache of my life. Just bam, maximum intensity, almost instantly. Because the blood is mixing with CSF and irritating the meninges all around the brain and spinal cord, patients also typically develop signs of meningeal irritation. A stiff neck, neutral rigidity, sensitivity to light, photophobia, maybe nausea and vomiting.
So worst headache ever plus stiff neck strongly suggests subarachnoid hemorrhage.
Very strongly. It's also a medical emergency requiring investigation to find the source of bleeding and prevent rebleeding, which is common and often devastating.
Okay, extradural from arterial tear due to trauma, lucid interval, subarachnoid from aneurysm rupture, sudden worst headache, meningeal signs. Got it.
What?
We have really covered a lot today. We finished this deep dive looking at the face and scalp's soft tissues, their complex nerves and vessels, and then moved inside to the brain's protective layers, the meninges, the dural sinuses, and the critical differences in brain bleeds.
Yeah, we've seen that these aren't just surface structures. The face and scalp are packed with clinically relevant anatomy, high-risk vessels, crucial nerves, and the meninges provide this intricate system of protection, support, and fluid management that's essential for brain function.
So what's next? Where do we go from here?
Next time we finally push past all the coverings and get into the main event, the brain itself, we'll start exploring its major parts, its own complex arterial supply, and then shift focus to the specialized anatomy of the orbit and the eye, how we actually see the world.
Looking forward to that.
But before we wrap up, here's something to think about. Circling back to those valveless veins we discussed. Consider that connection between the veins in your torso and the sinuses at the base of your brain. If you do something that really ramps up pressure, maybe straining intensely during exercise, or even just a violent coughing fit, could you just for a moment be forcing venous blood and whatever might be in it to flow backwards up that vertebral plexus, potentially reaching the spaces right next to your brain? It highlights just how interconnected seemingly distant parts of the body really are.
A slightly unsettling thought to end on. Thanks for listening to Bookfulness.